The Developing Well Child, Part 1. Immunizations are very important, and knowing the schedule is also very important. Knowing when to give them and when boosters are due, etc. Many immunizations require more than one immunization to provide full immunity. DTaP is diphtheria and tetanus toxoids and acellular pertussis vaccine. It's given at 2, 4, and 6 months of age, with the fourth dose being 6 months after the third dose. So it can be as soon as 12 months if the child stays on schedule. The final dose will be given between 4 to 6 years. The IPV is inactivated poliovirus, given at 2, 4, and 6 months of age. Again, their schedule is the same as the DTaP. These two are sometimes combined into one vaccine, but it is generally oral. HIB is Haemophilus influenza type B conjugate. It's given at 2, 4, and 6 months of age, and then again between 12 and 18 months of age. The MMR is measles, mumps, and rubella, given at 12 to 18 months of age, with the second dose at 4 to 6 years of age, usually prior to the child starting school. Varicella is given between 12 to 18 months of age, with a booster between 4 to 6 years of age. Hepatitis B is at birth, 1 to 2 months, with the third dose between 6 and 18 months of age. The third dose can be given no earlier than 24 weeks of age. The pneumonia or PCV is given at 2, 4, 6 months and between 12 and 18 months of age. Certain high-risk groups will get another dose again at 4 to 6 years of age. The meningococcal is given at 2 to 6 years for certain high-risk groups, and it's given to the college-aged prior to moving into dorms. And some dorms will require this. For example, the University of Kansas requires the meningococcal vaccine prior to moving into their dorms. Influenza is given yearly from the age of 6 months through 5 years, and then only to high-risk groups or those around people who are at high risk. Many vaccines, again, are going to require booster shots in the early adolescent or teen years. We administer no live virus if the child is immunocompromised or they have an immunocompromised caregiver, the child is pregnant, they have bacteremia or meningitis, they're on corticosteroid therapy, or they have a history of a high fever following previous immunizations. If you look in your book, Table 32.6 has the immunization schedule, and I also have a slide in a couple slides. For unexpected responses, you need to watch for the commonly observed reactions, which are localized erythema and induration, but anaphylactic reactions are something else that you need to watch for. There's usually localized tenderness, a low-grade fever, behavioral changes such as appetite, drowsiness, fretfulness, prolonged or unusual cries. To help reduce side effects, make sure that you use the correct needle size for the child's size. And to decrease the risk of anaphylactic reactions, consult an allergist if a previous reaction has occurred, and be sure that a synthetic stopper is used in the vial as opposed to a latex stopper. Administer Tylenol for fever as needed, and you can use preparation H on the injection site to help decrease tenderness. Personality is defined as the unique organization of characteristics that determine the individual's typical or recurrent pattern of behavior. The development of logical thinking and conceptual understanding is a complex process. Cognition is intellectual ability. We are born with an inherited potential, but you have to develop that potential. Moral development is a sequential development. There's 3 different levels. We have pre-conventional, which is 4 to 7 years, where the child attempts to be obedient and they fear punishment. Conventional is 7 to 11 years. This is where the child conforms, they do demonstrate loyalty, and they tend to obey the rules. And post-conventional is where the moral values are developed. Now, parents have to make changes also as their child begins to grow and develop. And Table 15.5 will outline the parent's tasks and interventions for each age, but I'm going to list a few here. At birth, the child's task is to adjust to the external environment, whereas the parent's task is to elicit positive responses from the child and meet the child's needs. Unfortunately, negative responses from the child can inhibit parental development. With the infant, the child's task is to develop trust, and the parent's task is to learn the infant's cues to determine their needs. The toddler's task is to develop autonomy, and the parent's task is to accept growth and development and some loss of control at the same time they're maintaining safety. With the preschool child, the child's task is to develop initiative. The parent's task is to learn to separate from the child. The school-age child's task is industry, where the parent's task is the acceptance of the importance of the child's peers. They need to accept some rejection from the child and learn to allow the child to do things for him or herself. And it is suggested to provide chores. The adolescent's task is to establish identity, accept body changes, and develop abstract reasoning. They begin to decide on a career and lifestyle, and they need to control their feelings. Whereas the parent's task is to not expect total control and let the child live his or her own life within reason. Expect to be discredited by the teenager at times. In other words, mom and dad don't know anything. And expect opinion differences. Respect them and guide the child. With growth and development, the process of development is the mastery of a skill that allows the infant or child to progress to the next skill. Metabolic rate is greater in children than in adults. With the infant, their growth. During the first 6 months of life, their body weight will typically double. Their birth weight is tripled by 12 months. In the last 6 to 12 months of the first year, their weight gain begins to slow down to 3 to 5 ounces a week. During the first 6 months, height will increase approximately 1 inch a month. They're almost 50% longer than their birth length by 12 months. Infants' height usually increases 0.5 inches a week in the last 6 months of the first year of life. Male infants generally weigh more and are slightly longer than female infants. There's more detail in box 16.1 in your book. Development of the infant, the most important physiological change in the newborn has to do with breathing and lung function. It helps to change the fetal circulation to newborn circulation. The first pattern of development, and if you look at your picture, you see this lined out, is your cephalocaudal or head to toe. The second pattern of development is peroximodistal, or the midline to the periphery. They tend to have shoulder control before they have hand control. The third pattern of development is differentiation, where they differentiate between simple to complex activities and functions. As the infant ages, they become able to hold and pick up objects. transfer objects from hand to hand, bang objects on the table, roll over, sit up, crawl, pull themselves to a standing position, walking or near walking by 12 months. And figure 13.3 will outline infant development in your book. With the toddler, growth slows as the toddler tends to become picky about what foods they'll eat, and the habits become more erratic. The birth weight is usually quadrupled by 2.5 years of age. The average toddler will gain 4 to 6 pounds a year. The height at 2 years is approximately 50% of the eventual adult height. Height tends to increase by 4 inches per year. With development, their walking becomes more and more coordinated. They can climb up and down stairs, jump in place with both feet, turn pages in a book, but usually several pages at a time, kick a ball, throw a ball. They learn bladder and bowel control. By the end of 30 months, they can build a tower, stand on one foot just for a minute, walk on their tiptoes, gain hand and finger coordination. They have an increasing comprehension of language. They speak simple, common words with gradual improvement in pronunciation and vocabulary. They're able to identify or name objects. They feed themselves finger foods with improving ability to awkwardly use eating utensils. And you'll find more detail on Table 17.1. Preschoolers gain an average of 4.5 to 6.5 pounds per year. As far as growth development, their weight at 1 year is doubled by age 5. They gain an average of 3 inches between ages 3 to 5, and the preschooler continues to be very active, so they begin to slim down and shed excess baby fat. As far as development, they can build a tower of 10 or more cubes, stand on one foot for several seconds, ride a tricycle, dress themselves in simple clothes. They're able to undress themselves. Their vocabulary increases from 900 to 2100 words. They begin to be able to skip and walk up and down stairs with alternate feet, catch the ball, use scissors. They may be able to tie their shoes, use eating and writing utensils pretty well. They're independent in categories of personal and social, fine motor, adaptive, language, and gross motor skills. Excuse me. Table 18.1 has more detail for you. There are different developmental screenings available. For example, the Denver Developmental Screening Test. It assesses the developmental status, not the intelligence, of children through the first 6 years of life. Now, I have a problem with the Denver Developmental Screening Test because if the child has not learned how to do the things that they're tested on, then they may not score very well, but that, in all honesty, has no reflection on their true developmental abilities. For example, if a child never uses building blocks, and building blocks are one of the skills that they have to perform, building different shapes, but they use Legos all the time and they're very competent at building with Legos, is that necessarily an appropriate determination of their development? School-age children. Yearly weight gains of 5.5 to 7 pounds is normal, as is a yearly height gain after 7 years of 2 inches. The birth length usually triples by the age of 13. Developmentally, they grasp more and more complex thought processes with reading, time, concepts of space, cause and effect, etc. They have more fine motor control, and they become very friend-oriented. And Table 19.3 has more of these details. And finally, with adolescents, their growth spurt, they have an adolescent growth spurt, which is abbreviated AGS, where the body begins to assume an adult appearance. The child becomes long-legged and gangly as body parts begin to mature at different ages. They have a rapid acceleration in weight and height gains. Boys tend to gain 15.5 to 66 pounds and 4 to 12 inches in height. Girls gain 15.5 to 55 pounds and 2 to 8 inches in height. The weight gain usually comes first, and then in 4 to 6 months they usually will start to gain the height. The age of onset, intensity, and duration of AGS will vary in each individual. It usually occurs between 9.5 and 14.5 years in girls and 10.5 and 16 years in boys. With development, they become more socially oriented. They begin to experience adult emotions and/or thinking. They're very peer group impressionable, and they begin to develop a tendency towards introspection. They also seek to establish their independence. More details are available on Table 21 in your book, 20-1. Cardiorespiratory in the infant. There is a close proximity of the trachea and bronchi, which makes it easier for them to transmit infections. They often have a sinus arrhythmia. They have an increased heart rate with inspiration and decreased heart rate with expiration. In the toddler, as the circulatory blood volume is less than adults, even small amounts of blood loss, including lab tests, can be compromising, as it is in the infant. Hypotension is a late sign of problems. The toddler can remain normotensive until 25% of the blood volume is lost. It's important to assess capillary refill. It should be less than 2 seconds. The lengthening body and decreasing fat thin the chest wall, and it makes auscultation of the lungs and the heart sounds easier. In the toddler, the alveoli are not fully functional, so it's important to watch for a rapid onset of respiratory distress. Their airways are small and very easily compromised, so they can have a rapid progression into respiratory distress. Observe for the flaring, grunting, retractions, and dyspnea. The tracheal diameter of a toddler is approximately the size of an adult little finger. Even mucus can obstruct the toddler's airway. Their tongue is large in proportion to their mouth, so airway obstruction is very easy if they seize, and it can lead to a loss of consciousness. The larynx cartilage is softer than in adults, and its position is more anterior. Don't hyperextend the neck because it can occlude the airway as it can in the infant. Ear and internal throat structures still remain short and straight, so otitis media, tonsillitis, and upper respiratory infections are very common. In the school-age child, cardiovascular and respiratory systems develop in size and capacity to meet their increased activity level. Their heart growth will slow down. That assumes a more vertical position in the chest, and the diaphragm descends to allow for lung expansion. Their pulse and respiratory rate slow down. Their tidal volume doubles. The average apical pulse is 90 to 95 beats per minute at rest, and average respiratory rate is 20 breaths per minute at rest. In the adolescent, the heart will almost double in weight, and it increases in size by approximately 1/2. They have a rate of growth slower compared to other systems. The pumping mechanism is somewhat ineffective in the adolescent, and this can be one of the causes of fatigue and complaints of inadequate oxygenation in the adolescent. Their lungs do increase in length and diameter, with the respiratory rate averaging 15 to 20 breaths per minute. And males have a greater vital capacity capacity, volume, and rate because they do have a larger chest size. Gastrointestinal. It's important to encourage tooth care as an infant and toddler. With infants, digestion occurs in the stomach and duodenum. Some solid foods pass incompletely broken down in the stool. In other words, you see pieces of corn or peas or raisins, etc., in the stool. Teeth will begin to erupt at the ages of 6 to 7 months. With the toddler, they have increased eye coordination for grasping, eating, and drinking, and bringing food to their mouth. Their stomach capacity increases. It's less frequent. Larger meals are required due to the increase in appetite and erratic eating. Serving size should be about 1 tablespoon per year of age. Primary dentition. They usually have about 20 deciduous teeth, or their baby teeth, by about 30 months of age. The chest circumference continues to increase and exceed the abdominal circumference, and the lateral diameter exceeds the anterior-posterior diameter, exceeding the abdominal girth by year 2. With school-age children, they begin the shedding of deciduous teeth and have the eruption of permanent teeth at about 6 years of age. Need to encourage breakfast, and these kids can go longer in between eating periods. And the adolescent, again, they're always hungry because of rapid growth. It's important not to neglect deciduous or baby teeth. Not only does it help in their digestive process, but these teeth help in their jaw development. If these teeth are lost too early, the permanent teeth can come in poorly aligned. There is a delayed or early eruption. These could be indicative of certain endocrine disorders or other pathological conditions. It's important to eat a healthy, balanced diet to enhance tooth development. They need to avoid processed sugars in food and drinks as much as possible. And realize that sticky foods have the potential to cause more dental caries or cavities than sugars do. Dental caries, again, or cavities, occur when the infant falls asleep while breastfeeding or putting an infant to bed with a milk or a sweetened drink. Dental caries in young children anyway. Tooth hygiene, again, starts with the first tooth eruption. They should brush morning and evening. Toothbrushes should be replaced every 3 months or after a viral illness. Brushes should not be rinsed in hot water. Realize that sucrose in medications can cause tooth decay, and tooth can erode from acid from the stomach when they begin to vomit. There's frequent urination in infants, so that can put them at a risk for dehydration due to immature renal structures. With the toddler, sphincter control will enable bowel and bladder training. High fiber and fruit juices should be given to help prevent constipation, but understand that large quantities of fruit juice can cause diarrhea. Their bladder capacity increases to allow the retention of urine for a couple of hours. Bladder and kidneys reach near adult functional level by 18 to 24 months. It kind of coincides with their ability to walk. The urinary bladder is positioned higher in the abdominal cavity than in adults, and you can palpate that bladder between the umbilicus and the symphysis pubis. Their urethral structures are short, about 2 centimeters or 0.75 inches, versus the adult, which is 4 centimeters or 1.6 inches in the female and 8 inches in the male. Toddlers are susceptible to UTIs, so you need to wipe them and teach them to wipe front to back. Encourage voiding at breaks instead of holding it in. And toilet training begins in the toddler years, with bowel training occurring first because it's more regular and predictable, and bladder training will usually follow. Now, it doesn't always happen that way, but. And school-age children, enuresis is considered voiding urine, but it's usually considered to be voiding urine at inappropriate times. Diurnal is during the day, and nocturnal is at night. If there is abnormal voiding, you need to consider organic causes first. It might be a behavioral cause, and it might be that the child is sleeping too soundly. Neurological. The infant has rapid brain development during the infancy period. In the first 6 months, head circumference will increase by approximately 1/2 an inch per month. By the end of the first year, the brain is 2/3 the size of the adult brain. The posterior fontanelles should close by 6 to 8 weeks of age, with the anterior fontanelles closing between 12 and 18 months. If they close too early, then surgery may be required to break the skull and try to allow room for that growth of the brain. With the toddler, again, the anterior fontanelle closes by 12 to 18 months. And the brain growth begins to decelerate, reaching 80 to 90% of the adult size by 3 years of age. As brain growth slows, the head and body becomes more proportional. Cognitive development is demonstrated by rapidly expanding vocabulary. They do have control gained over most reflex activity, and cord myelinization is complete at approximately 24 months of age. They're usually not able to have bowel or bladder control until that is complete. Toddlers learn by observation, touching, tasting, and mimicking what they see and hear. With school age, myelinization within the brain is completed by age 7. And with adolescence, brain growth will continue, and by age 12, brain size is comparable to that of an adult. It is reflected in their increasing ability to think abstractedly and hypothesize. The integumentary system with the adolescent, we have sebaceous glands increasing in size as they become active, with an increased risk of acne. In the males, their skin tends to become darker with a thicker texture, and it begins to toughen. And females tend to have soft, smooth skin with fine hair on their cheeks and upper lip. Don't overlook infants, though. They tend to have milia. It's frequent for them to have a rash or a diaper rash. Infants' legs are often in a flexed position with an internal rotation up to 4 to 6 months of age. They have a C-shaped curvature, and their feet tend to turn inward or outward. The toddler's bones continue to lengthen and strengthen as the toddler continues to grow, and more of that baby fat turns into muscle as the child is oftentimes more active than they were as infants. They learn to do more tasks independently, but they still require assistance with more complex tasks. Pot belly fat begins to turn into muscle. They have a progressive independent activity. Their gross and fine motor skills refine as the child learns to walk or turn pages, zip zippers, build towers, ride a bike, brush their teeth, or dress themselves. By 36 months, their large and small muscle groups enlarge, and they have physically observable actions that are refined. Their gait is usually wide and unstable. Now, if a child does not walk by the age of 18 months, they should be assessed. Preschoolers can appear bow-legged or knock-kneed, which usually will resolve by age 5. And by age 6, their gait tends to resemble an adult's gait. Adolescents, The full bone length is reached in extremities and it begins to move inward. The trunk growth begins with lengthening and widening of the hips, commonly in the females. And then it involves the broadening of the chest and the shoulders, more commonly in the males. Subcutaneous fat will decrease in the males and increase in the females. Fat is deposited more commonly on the trunk in the males, over the thighs, buttocks, and breasts in the females. And sexual maturity. Puberty is the maturational, hormonal, and growth process that occurs when the reproductive organs begin to function and the secondary sex characteristics begin to develop. It may be divided into 3 stages. We have prepubescence, which is the period about 2 years before puberty when the child is developing preliminary physical changes. Puberty, which is the point at which sexual maturity is achieved, and it's marked by the first menstrual flow in girls and the less obvious signs in boys. And postpubescence is the 1 to 2 years following puberty, where the skeletal growth is completed and sexual maturity is also completed. Adolescence is defined as the psychological, social, and maturational process initiated by the pubertal changes. Hormone changes in the males is the production of sperm, and in the females it's the release of ova. And they also begin secreting sex-appropriate hormones. Estrogen and progesterone from the ovaries and testosterone from the testes. So let's look at the girls. We start off with thelarchy, which is usually the first sign of puberty. It's the appearance of the breast buds, and it can occur between the ages of 8 to 13 years. Adrenarche is the growth of pubic hair. Occasionally, hair growth may precede breast development. It occurs approximately at 8 to 12.75 years for Caucasian girls and 7 to 11 years for African American girls. And menarche, which is the initial appearance of menstruation. It occurs approximately 2 years after the appearance of the first pubescent changes. There is evidence that girls are developing secondary sex characteristics at a younger age, but so far the powers that be have no explanation for this change. In boys, the first pubescent change is testicular enlargement, and it usually will begin to occur about 9.5 to 14 years of age. It's also characterized by the initial appearance of pubic hair. Penile enlargement begins to occur. They have increasing muscularity and voice changes, and the development of facial hair. Some boys may have slight breast enlargement and tenderness. And voice changes. Girls' voices tend to become slightly deeper and fuller, where boys' voices tend to shift, often uncontrollably, from deep to high tones in the middle of a sentence as those vocal cords begin to grow.